We have with us Dr. Yan Chow, the director of Kaiser Permanente's Innovation and Technology Center, and Dr. Molly Coye, the Chief Innovation Officer at the UCLA Health System. Could you start by providing us with an overview of the KP Innovation and Technology Center,
Sure.
its history, its objectives, and how it fits within the broader Garfield Innovation Center at Kaiser?
First of all, it's great to be here. Thank you for inviting. The status of innovation at Kaiser is kind of an interesting question because Kaiser itself has been always very innovative from the beginning. But starting in the early part of the 2000 decade, we started to think about the future and how things were changing in healthcare and looking at the whole concept of patient-centered care within an integrated system. So by the time that 2006 rolled around, we decided that it would behoove us to actually look at the new and emerging technologies that were coming to healthcare within the next decade time frame. So we created two things. One is the Garfield Center, which is an innovation center that's just across the bay, right next to Oakland Airport. It's a 37,000 square foot facility. And it's built as an advanced care delivery simulation lab, which means that we test space design, we test technology, and we test sort of workflows in as real an environment as possible without creating risk to patients or operations. So in the center, we have an entire medical surgical ward of the future. It's a triangular design. It's a pretty cool design. We have an OR of the future, labor and delivery suite. We have a single-bedded newborn ICU design. We have a microclinic design. We have a home environment to test telehealth, telemedicine. And we also have a patient room of the future, which is undergoing development right now. So that's the Garfield Center. It's a physical facility. We've had over, I would say, 48,000 visitors in the last 6 years from 42 countries. Because I think the idea of a simulation center in healthcare is really unique. I'm not aware of anything else like that at that scale, although in other industries, it's not so unique. There are a lot of industries that create these simulation centers so they can test their products, test the implications of products before you roll it out and have to roll it back if it doesn't work. So that's one thing that we created. The associated group with that is my group, which is the Innovation and Advanced Technology Group, which is part of IT. And what we do is we actually are the think tank. We are the R&D group. So we go out there and this is kind of like the old Star Trek. We go out there and go where people have never gone before, looking for new things. And we have a very wide funnel. So we've looked at telehealth, mobile health. We've looked at analytics, big data, looked at robotics, virtual, all kinds of realities, virtual, augmented reality. In my day, when I was going to college, that meant a different thing, realities. I'm cross-generational. We've looked at social media, clinical gaming, genomics, all kinds of things that affect IT. And we've probably seen over 1,500 technologies the last 6 years, of which we've done deep dives into about 200, and about 10 have gone into production. So that's on the outside facing. On the inside facing, we have an innovation fund program that is available to any Kaiser employee who has a good idea. And the funding is on the level of angel investment funding. So the catch is that they have to do it within 6 months to a year or so. So we've funded about 79 out of the 600 applications. We've funded 79, about 14 of them have gone into production. And they actually range from things like a dashboard for hospital capacity across the region to things that are very theoretical, such as a latest RIM database format that's been embodied in database and so on. So a lot of variation in the kinds of technologies we see, but it's been a very interesting time in healthcare. I think right now, for many reasons, things are happening in healthcare and coming together that I've not seen in 30 years.
Great. Yeah. So in our earlier conversation, you mentioned that of all these areas, you are now focusing on 3: telehealth, mobile health, and big data analytics.
Right.
So can you tell us a little bit how you started with these 20 areas that you mentioned earlier. And why did you end up narrowing down to these three? Is it the viability of the technology? Is it the fit with KP strategy? Is it the potential of clinical practice? What guided your thinking in choosing these three areas?
That's interesting because there's always, for KP, it's always you have to be aligned strategically as an organization, and sometimes that's difficult. But I think in telehealth, that's actually pretty clear. It's one of the areas that's one of the most mature. It's been around for many, many years. Technology is not new. It's had its challenges. You kind of wonder why hasn't it been adopted. But I think there are now pressures in terms of cost pressures, in terms of the scarcity of physicians and clinicians, in terms of the chronic conditions that are so costly that we're hoping to take care of at home and at the workplace. Those kind of pressures are creating a huge interest. Right now in Kaiser, I think I believe there are over 100 pilots right now in telemedicine in the three modalities. There's the video consultation thing, there's a store and forward, there's a remote monitoring. And there are a lot of barriers, and we can go into that later, but I think that area is going to be probably the near-term hope for healthcare reform. That the technology is going to provide answers in that area that will help address some of those issues. It's interesting, if you Google healthcare reform, one of the top words that comes up is technology. So people are thinking technology. The second area is mobile health, and that's been driven by consumer trends. I think the mobile device, the smartphone, has actually supplanted the PC as the electronic tether of choice. And that means that Kaiser recognizes that, as do many other organizations. So we actually are developing many different channels for those mobile devices and the next generation mobile device, whether that be a Google Glass or some other device. Things will evolve. But we see that as an opportunity really to develop a new kind of relationship with our members. Instead of, when you think about a mobile device, you have it all the time. It's always on. You're always connected. It's a very personal device, and you tend to use it like an for ad hoc needs. So the opportunity, I think, is there to develop a relationship where we can be more like an advisor as opposed to a crisis responder. And I think that's very exciting. And the third area is analytics. Right now, there is a huge push of federal funding, federal stimulus funding push towards meaningful use and adoption of medical records. And I think that's going to be the focus for the next 3 years. But in 2015, when people have finished doing that, there'll be a huge need to do analytics for quality reporting, performance reporting, and reporting on many things. And I think for the regulatory reason, that's going to drive analytics. And I've seen probably over 24 analytics companies, startups, in the areas of data visualization, in the areas of natural language processing, in the area of making big data and analytics available to the common end user, which is really important because if you have to require a data scientist before you can make use of big data, that's not sustainable. So I think those three areas are focus areas for us for many good reasons. But who knows? As time goes by, I think there'll be many other areas that'll be important as well.
Okay. Let's talk a little bit about big data. So when you start looking into these possible application areas, how do you determine which of those application areas would be more promising or more fruitful for you to explore?
Well, I think in big data, there's actually 4 areas that have had published use cases in medicine. There's been the clinical care delivery area, so that's decision support, predictive analytics, things that, and it sort of boils down to questions like who's going to come back within 30 days of the hospital after discharge, things like that. And then there's the sort of the public health area, which has a number of applications that have been published. And then there's the research area. It's kind of interesting, the research area. You think about big data and how much data is coming into the medical world today. There's just no way to handle that. There was one study that showed that if you're an epidemiologist, it would take you, to keep up with your field, it would take you 21 hours of study a day. So what does that tell you? It tells you that nobody can get with your field. It's very difficult. So what is the role of the physician? What is the role of the data manager? I think those areas are are things that the medical community is just starting to grapple with and starting to discuss. There's also an issue of random clinical trial-driven data versus statistical data. And I think that's also another issue that hasn't really been discussed a lot by the medical community, but it's starting to be discussed, because the question is, we have big data, can we practice correlational medicine or not? You know, do we have a basis to do that or not? The medical community has to come to some agreement on that.
So where is that going? Now I'm just intrigued by that question.
Mm-hmm.
I have a colleague who worked on that problem, and he submitted a paper to medical journal, and the response we usually get from medical journals when we look at correlation studies is correlation is not causation.
Right.
And those of us who are in the data analytics field, sometimes we just are ready to throw our hands up and say, wait a second, we are identifying a correlation here is meaningful. We are the kind of people who can look into these questions. Maybe we're not going to be able to give you the causation, but somehow we need to start to begin the dialogue. So what are the challenges in starting to have this dialogue about getting information from those correlations and turning those informations into something that is meaningful, that can change clinical practice?
I think I sort of see it as the analogy is like this. Random clinical trials, hypothesis-based evidence-based, what we call evidence-based medicine, which is something that's really important at Kaiser, is identifying causes and because of that, solid evidence to base your practice recommendations on. On the other side of the spectrum is anecdotal medicine, which is how most physicians practice. Why? Because their patients don't fit into the clinical trials. So they have to extrapolate anyway. And so it's interesting, there was actually a startup that brought this issue up as I started to talk to physicians at Kaiser. The issue of anecdotal medicine or reality medicine versus ideal medicine, gold standard medicine. There's a value for both, because in many cases, the clinical trials haven't looked at those kind of patients. And so now we have data-driven medicine. What does that mean? Instead of anecdotal medicine where the physician practices based on their limited experience of 60 patients, they suddenly have a database of 100,000 patients. Does that make their practice more valid or not? It's not causal, but it certainly indicates what could be causal. And so I think the role of both is really important, but maybe the different roles. And the data-driven part maybe can suggest things that we can test on this side. Problem is testing with clinical trials means 5 to 7 years, lots of money, and so on and so forth. Yeah. Hard to keep up with the pace of change.
Exactly. Yeah. So when I visited you at the Garfield Center last fall, you spoke very eloquently about the challenges related to the adoption of new technologies and new delivery models and creating new standards of care. Can you describe some of these challenges and what Kaiser Permanente is doing in approaching the adoption of new care delivery technologies and processes?
Well, I'd like to mention that there's actually a spectrum in terms of new technologies we look at, from things that touch clinical care to things that don't. And so the closer you get to clinical care, the closer you get to the FDA. That's basically it. That means the burden of proof is much higher and higher and higher. But there are a lot of technologies that are very helpful and enhance workflow and efficiency, et cetera, increase the quality of care, that are not regulated by the FDA. So the question is, where do things go? And in our organization, when things get towards the clinical practice part of the spectrum, then you have to raise issues like reimbursement. Okay, that's a huge issue, especially today. Issues of standard of practice. Is it a best practice? Who's going to defend you if something goes wrong? That's a standard of practice issue. There's issues of understanding the business model, or I would say the lack of understanding of the business model. The workflow disruption of telemedicine is huge. You have to work it into your regular practice. How do you do that? How do you create the physician resources and the time to really handle a full telemedicine practice, holding the promise of cost savings and efficiency, but requiring a lot of redesign and a lot of thinking. There's issues of metrics. In fact, right now there's a debate in the literature about what is the right way to measure telemonitoring programs. Maybe using the traditional metrics like length of stay, mortality, readmission rate is not the best way to go. Now people are suggesting You should measure hospital efficiency, member retention, things like that. And maybe that's why the studies have not been consistent in the telemedicine literature. There's issues of security, and that's always a big issue, very, very big concern to most healthcare organizations. People are just starting to explore that in mobile apps, in applications, in sending data outside our organization. And there are even providers, there are even startups now that are creating platforms that you can develop on that are, quote, HIPAA certified. You just wrap your app in a HIPAA wrapper, things like that. But it's a big issue. It's a huge risk. And of course, technology always runs ahead of regulatory and legal. And so it's a risk. There are physicians out there on the edge, but if things go well, that's great. If things don't go well, you have nothing to stand on. So if you look at the specialty sites, I looked at 30 specialty sites. About 2 of them mentioned telemedicine in any way. So it seems to be that most specialists are not really thinking about it. But I think in the ACO setting, in the cost-cutting performance setting, they will start to do that.
So you see a trend, because you see that there are tailwinds that are going to help accelerate the adoption of telehealth technologies.
On the other hand, for the innovations that don't touch clinical care, and like I said, we've had 10 that have gone into production, we are running an internal innovation fund, so that gives some money to people to to embody their idea, to prove it out. But there's always has to be somebody in the organization that's a stakeholder that pulls it. We don't push it. There has to be some way for somebody to want it. And that's wanted on their priority schedule, wanted on their timing, wanted on their budgeting cycle. For instance, when we put in Health Connect, 2003 we started to do that. We didn't finish till 2010. That's 7 years, 9 million patients. During that time, if you were a startup and you were to come to Kaiser and say, look, I have a telemedicine technology, we'd go like, talk to us in 5 years. Because we were so focused on the medical record, it was so important to get it right. And so the timing is very important for, when you approach an organization like Kaiser versus, let's say, somebody else who's not quite as far ahead. So there's very, very different priorities.
Great. So I'm going to turn now to Arnie and Molly. I'll make a quick introduction to introduce Arnie, primarily because I want to say that Arnie is the kind of academic that makes us very envious in the following way. So Arnie actually had this very significant impact on the practice in his field, the field of medicine. Before he joined academia, he was leading the healthcare practice at Mercer. He's a member of the Institute of Medicine. A lot of the innovations that you are aware of in the healthcare delivery space, public reporting, a lot of the Institute of Medicine reports involve work that Arnie was a part of it and pioneering that work. And now he joined the faculty at Stanford the last couple of years, and he's helping us define a research field out of a field that was proven to be very effective in practice. And Arnie is going to have a conversation with Molly about their work on innovation.
Thank you, Stefanos. Molly, I think it's probably the dream of a lot of people in the audience to be brought into a large, sophisticated health system as a senior leader and be permitted to define your own job. And that was what UCLA needed to do to attract you, because you were, at the point they hired you, a globally recognized expert in innovation in healthcare delivery, especially technology-based innovation in healthcare delivery. So you arrived there, and now it was time for you to figure out what you would do. And it was, what would your job be at UCLA? What was your thinking, and where did you land?
Well, first of all, I kept a close eye on you to make sure that I knew what I was supposed to do. But if you look around the country, the innovation centers that have existed in major medical centers like Cleveland Clinic or CIMIT at Partners and in Boston are mostly about tech transfer. So they're basically about inventions within those academic systems and how you bring them forward for commercialization. But there is a new type of innovation center that's arising, and our center at UCLA was one of those, which says that we are under the gun to transform the delivery of care, to take out roughly a third of costs, to make the patient experience much more, to meet the needs of the patient. And so in order to do that, and also to, along the way, increase quality, given the sort of quality down around our ankles phenomenon that we face now. And so with those three goals, the idea on the part of some health systems is that innovation is not necessarily about inventing it yourself. It's about identifying the innovations that will serve as accelerators for your strategy. So it's very closely aligned with strategy. For our academic institution, we're one of the relatively few ones that has 3 decades of experience with managed care, 250,000 primary care patients, 100,000 of them in risk products, either full or professional side risk. So we defined 3 principal strategic goals that we would work on for innovation. The first one is population health management. How do we grow from 220,000 patients to 1 million under management within 4 to 5 years? We've got to set a goal, so we set a stretch goal. And do so in a transformed way, so we're not just multiplying our current system of care. The second one is very closely aligned, like population health management, is telehealth. How can you take the expertise of our tertiary quaternary experts and make that available to a much larger number of patients with a bigger geographic reach without building more towers, hiring a lot more academic experts? And the third one is how do you, from the patient point of view, improve access? Because most desirable tertiary quaternary centers, their clinics are jammed. You know, we had 3-4 month waiting lists for a lot of our care. And so we've been focusing on access, including e-consult kinds of systems, remote telephone answering for a very broad population, a whole series of solutions in that area.
Terrific. Well, so maybe you could focus in on one of the areas in which you bet, which is telehealth, and maybe just give us your thoughts on why that area among the many choices, and then maybe a tangible illustration of the things you saw in that category, the one that you think allows you to tell the most compelling story of value add, whether it's taking 1/3 of cost out of care or improving patient experience or population health.
Well, first of all, the thing that I think is really important, and not having the luxury of a 10-year run at this and having followed much of what Kaiser's doing very closely with a lot of admiration, we really felt that we had to go for those interventions that were liable to get something between a 10 to 30% swing in whatever our goal was. In other words, if it was cost reduction, if it was improved access, it had to be something that really moved the needle. That didn't mean that incremental improvements weren't welcome, but we just couldn't focus a lot of our resources on that. So within telehealth, we started with tele-ICU. And I don't know how many people are familiar with the e-ICU, tele-ICU concept? Good, a lot of people. Well, for those who don't know, within the next month or so, we'll be posting our study of that issue on our website at UCLA's Innovation Center, because we've spent the last 2 years working with our faculty internally and doing a very close scan across the country. And pretty much across the board, including academic centers like Penn and University of Amherst and community hospitals, there's about a 20% decrease in mortality when they put this system in. And roughly concomitant decrease in the length of stay, the cost, complications, a whole series of things. There are a small number of companies across the country that are actually offering this from a commercial center remotely, rather than just doing it within their own health system. And so it's no longer really innovative to do the eICU. It's now managing 13%. So there's really one provider, one company out there. Philips bought the venture-backed company. But 13% of all beds, ICU beds in the country, are managed using the eICU system. So we're pretty close to the Everett-Rogers tipping point. If Everett understood our healthcare system, which I sometimes doubt, it should mean that this is going to start taking off. But basically, we felt this was a very important thing to do, and that we could do this in partnership with hospitals around California. So we're still working on that, but we hope to be able to do that. And we think this would have a huge move the needle kind of effect. The second thing that we have seen in the broader telehealth area that moves the needle that way is the e-consult. Now, the e-consult doesn't start with remote video consultation. The e-consult system starts with managing access for specialty care. And it was invented, like, wartime makes is the crucible for inventions. It was invented in highly resource-constrained systems, public systems in California. And in 3 or 4 different major applications of this across 18 specialties, it's been reducing the need for a physical visit to a specialist by 40%, pretty repeatably. It varies by specialty, but averages out to roughly 40%. Well, given what we think is going to happen with the need for specialty care, especially with the 2014 impending onslaught of demand, as they saw in Massachusetts with health reform, that became a point at which it's very important to try to manage access to specialists. That if you can avoid the need for a visit to a specialist by having the primary care or the referring specialist be supported, it's really important. There are technologies that underlie each of these, but it's about the business and service model. So the technology for e-consult is simple HIPAA-protected email and a system for the cloud management of transferal of imaging. And we're using LifeImage for that. As we go from system to system, we use commercial applications because there are a lot of small companies that are very exciting out there. But you start with the strategic goal and the business model and the service model, and then you fold in the particular vendor that's going to meet your need.
Well, one of the criticisms of the health system relative to more value competitive industries is that I think the estimate was that for once something is clearly demonstrated as better, it takes on average about 17 years for it to get uptake. And Andy Grove, in his famous article criticizing the American healthcare system, said in his industry it's about 6 months, or you're dead.
Yeah.
And what's your sense as to whether or not the combined signals coming out of the private sector, as Mark was describing earlier, and the signals coming out of Medicare and Medicaid, whether those are finally enough to persuade providers to get much more interested in innovations that might reduce population health spending and improve quality than they typically have been in the past, because it's not it's obviously for entrepreneurs in the audience it's not been a happy life relative to entrepreneurs who are selling into the IT industry.
Yeah. Well, I think we're about to get a giant kick in the seat of the pants, frankly, as providers, because if you looked at a spectrum between 5 years ago where we basically didn't choose anything on the basis of value, it was all relationships and tradition, and you look at some ideal state where we're maybe not at an Intel level, but we're pretty good in terms of value shopping for our innovations and adoption, I think that with luck, if the exchanges come online and don't implode, which is a scary possibility, the pressure of the combined access needs and price pressures, I hope, in the private exchanges will finally start to drive that. We've changed in LA completely. When I was health commissioner, but I would go down to LA and talk to people there, and the medical groups in Los Angeles 15 years ago basically didn't even think Kaiser was a competitor. They were competing with each other, and they thought Kaiser would either maintain a very small, minimal presence or go away. Today, they all want to grow up to be Kaiser. They all see Kaiser as the entity to compete with. And that is the first stake in the sand in terms of a shift to a risk base. Now we just have to get you to bring your prices down so that the premiums go down so we can deliver the value. But we have to do that too, to be fair. So,
well, one of the challenges that anybody leading innovation in a health system has to deal with has been what one of your own faculty members, researchers, Dr. Brian Mittman, has described as implementation risk. And if you listen to him talk, he'll take given good thing in healthcare that's demonstrated in a clearly at small scale, and then he'll show how when you attempt to replicate at scale, sometimes as much as 85% of the effect size evaporates, because at the time the innovation was sort of defining the what of the innovation, but not the how of the innovation. As you now, will be held accountable for these innovations, generating the kind of double-digit changes that you outlined. How are you going about managing so-called implementation risk?
I actually think there is an emerging science around this. And Brian's a part of our advisory group, and so we took the warnings very seriously. And I know there isn't time to detail it, but we put together an innovation to transformation model that borrowed heavily from Kaiser and a bunch of other places. But it's a highly disciplined process. I know this sounds almost oxymoron for an academic center, but it's very disciplined and requires, so in 6 months in our primary care innovation model, we took out 20% of hospital admissions and 30% of ED visits, replicating a model that we had studied in other places. And we were month by month, tracking the metrics. And if we saw slippage, we would bring teams in and really push it. And we solved problems as we went, and we're continuing to track. And so far, it's not backsliding. So I think you can't get there by saying you're great. You have to actually perform. It's execution. And that's really the key. And so that's why I think many new businesses fail, is you can sell a great product into a health system that's no good at execution and doesn't have true belief that innovation is important to their strategic future, and it will evaporate just like Brian describes.
Well, if you look at, let's take the example you cited, the VisiQ, which now is Philips, and the early days of that company were nightmarish, for the founders. They were, running around saying, "Look at this." I think it was a 30% reduction they got in mortality at their initial site, and what would happen is someone from the health system who was, typically in the CFO office, would sort of look at the numbers, and then they'd go back and run the math. And for many years, they would run the math and go, mortality is not being especially, it's not visible at this point. And the truth of the matter is, if we reduce, a lot of complications, it actually is not going to work out for all that well for us financially. And the continued truth of that today was published in a very, an article that went across the internet yesterday in JAMA, which basically showed that not for Medicare, which has gradually become more value sensitive, but for the private payers, where essentially is the origin of all margin, in healthcare, it actually, what yesterday's article showed is that to this day, despite this general movement toward value, it was actually, hospitals actually were much better off with a higher rate of surgical complications, preventable surgical complications. So, so enter stage right, Molly Coye coming into UCLA. You have a CFO, and he, probably ran the math and said, gee, we only have 100,000 or 200,000 commercial lives where for many of them, we don't even have full risk. We've got professional, insurance risk, and somebody in that office had to be saying, this is not going to work out for us, Please, can you stop her? Yeah. How did you go about influencing the decision makers essentially to say, well, I don't think the exchanges are going to implode. I do think Medicare is going to get tougher and tougher on value. And I think that Cadillac tax, which we can talk about maybe in the subsequent session, is going to cause the commercial payers to be a lot more value sensitive. How did you win that argument? Because it is a little hard to call at this point whether or not we're about to see another managed care backlash or whether or not this is the way forward.
Well, first of all, I would say our CFO is pretty smart. He asked those questions 2 years ago. He didn't need JAMA to make him ask those questions. But I think that the real answer here is, remember I said that these are strategically aligned innovations. And part of the role of strategy is to see beyond the immediate 12-month bottom line. There is no question that it would challenge the bottom line of most systems. But we're at 110% occupancy. And a fair number of good systems are very high occupancy now. Now, it's true it's coming down, but if you look around, you don't have to sell to every system in the country to make a good, success of your business. And there are enough around that have reasonable occupancy and who have leadership who sees the strategy that you're building for that future. So for us, let's say one of our hospitals is 80%. But if we could get that 80% to be the cases we want to have in there, the tertiary quaternary ones, for every academic center, every large teaching hospital, a lot of those cases are just commodity cases. They're community-acquired pneumonia, that kind of thing, that had some complication. And so there are a lot more levers to pull, but that's why doing the innovation isn't sort of sloganeering. You have to dig in, and we did a lot of research to make the arguments. And I would say it's not for the faint of heart, but it is really fun when you get. And if I can just add one other thing, because it's credit to Kaiser for something really important. I gave up in waiting in line for the speaker, the questioning. But what I wanted to say is we were talking about end of life, and there's another 30% swing in terms of programs for end of life that was developed at Kaiser in Southern California by a community-based care organization that takes out 30% of net cost of care in the last year of life. Kaiser published the research, and it's now being disseminated throughout Southern California in Kaiser. And basically it goes into the home and does the palliative care in the home, largely with nurses and social workers. There is a physician involved, but it's really going to different types of healthcare workers and working with the family in their home. So it's possible to do this kind of innovation even without a huge technology platform.
Thank you, Molly. Stefanos, I want you to get in on the questions.
Okay, so what I would love to explore a little bit with both of you is what are the similarities and what are the differences between your approaches? And instead of asking the question like that, I want to ask it in a different way. What would you like to imitate from what UCLA is doing that you're not currently doing? And Molly, the reverse question to you.
I think that's a really interesting way to put it.
Nothing.
I mean,
I know.
yeah. I mean, at its core, Kaiser is a care delivery organization. And I think we actually have a very strong research department, but I think it would be one of the things I admire about academic institutions is that they actually look at everything and they actually have a sort of a design framework, a study design framework to look at things. And I think that's something that sometimes is missing from, let's say, market-oriented organizations. Many of the pilots that we do are locally focused. They have local problems they solve. They don't look strategically, and they certainly don't design the studies to create anything that you can learn from. I think that's one of the things I admire about sort of academic thinking. The other thing I admire is that many times the folks in academic institutions are the ones that see furthest into the future. And that talks about strategic vision. And I think that's really important because I think for a lot of healthcare organizations, you look at where they focus, it's very near term, very near term. If the government says we're not paying any more for 30-day readmissions, that's where they focus. We're not paying any for falls in the hospital, that's where they focus. That's very short term. And the concern to me is that there are these huge macroeconomic trends that are going on. Cost of healthcare, the scarcity of resources, no more physicians, and things like that they're going to drive people towards different kinds of care models. And the difference is, do we get there thoughtfully, or do we get there solving crisis one by one? And that's just, to me, that's not very attractive.
Well, first of all, I want your budget.
I'll write you a check.
But after that, I think that the thing I'm really jealous of is that you're in a risk-based, wholeheartedly in a risk-based system.
Right.
Because our greatest success so far, I've only been there 2.5 years, has been in what we call our primary care innovation model, where within 6 to 9 months, we started getting our physicians and our staff excited about those challenges And then they kept coming up with innovations as well as going outside and bringing things in. And it's just a very different environment from trying to deal within the fee-for-service system. And as someone with a public health background, I really hope we all get to the managed care kind of setting.
So I want to drill a little bit into that because when we started thinking about the session, I thought that this is a major difference between your two organizations. You're operating in a fee-for-service environment. You're operating in a completely take your own risk and manage your own risk environment. And I could infer from your earlier answers, Molly, that you believe that the underlying trends in the healthcare system are slowly moving us in an environment where fee-for-service is not going to be as prevalent, and organizations that know how to operate in a fee-for-service environment will need to learn how to take more risk and manage more risk. So is your strategy at UCLA driven by this long-term view, or are you still trying to balance the current reality of fee-for-service with a future environment where you see more at-risk organizations?
We believe that nationally in California, there definitely is a trend towards risk-based reimbursement. And so we're now have an ACO of 18,000. We're growing a commercial ACO contract. We're doing all the steps to try and grow that. And when I talk about our 1 million member goal, that is assumed to be mostly under risk. But as a tertiary quaternary provider, as an academic center, you're going to continue to get some of your cases internationally and nationally and regionally. So we're competing with Cleveland Clinic and Mayo, not with Kaiser, for the transplant patients and that kind of thing. So we have to have a little bit of both, but we think of the fee-for-service incentives as deforming to faculty behavior mostly. And so we're trying to inculcate more of the instincts and responses of the risk-based incentives. Because even in the tertiary quaternary, it's all about value. It's just that you're using a bundled episode rather than a year of a member's life.
Great. So I wanted to turn to you, Arnie, my last question, and then I'm going to open it up for questions from the audience. So, Arnie, you're leading our own center at Stanford that also has the flavor of a Center for Innovation in Healthcare Delivery. Can you share a little bit with the audience your approach and some of the key initiatives that you're driving through your center, and maybe how they link to some of the things that Jan and Molly spoke about?
Sure. It's at the Stanford Clinical Excellence Research Center. We're exploring the hypothesis that science-based innovation could, within relatively short periods of time, come up with new ways of delivering healthcare that would be both more affordable and more attractive to patients, and that wouldn't reduce clinical outcomes if not improve them. And as we begin to think about how would you bake such a cake in an academic center, the big pieces consist as follows during what I'll call phase one. They are first of all borrowing from some of the insights and disciplines of user-centered design, as pioneered by people like you, Stefanos. And so that's one ingredient. Second ingredient is to take it, in a methodical way, it's one of the things researchers do, is to comb the current published literature on which approaches to treatment for a given target condition generate better outcomes with less overall total spending. And then we add a few other ingredients to the cake. For example, we systematically network and shop the world, market to essentially understand, irrespective of country, what appears to be today's efficiency leaders in terms of health outcomes per unit of resources expended. And then lastly, to sort of stem off some of the risks of so-called brainstorming, we take advantage of both the faculty, diverse faculty here at Stanford, as well as some friends from our ecosystem in the Silicon Valley, and have them in ways that are not always welcomed by our research fellows, or by me, frankly. I get invested in these ideas to come in on a relatively regular basis and hear the nature of what's evolving, and say, yes, no, you better look into this further, or let me connect you with somebody who I think might have a better idea about that. And out of those, those primary ingredients comes what I'll call sort of the first generation of what we're doing, which is really defining the what of innovations likely to reduce cost, to lower per capita spending and improve quality. And then once we have those, we then go to the Kaiser and UCLA and health systems all over the country and say, a bunch of our fellows with some faculty supervision invented this new care model. Would you like to participate in a systematic study to figure out whether or not it indeed pushed us beyond today's clinical efficiency frontier? And when the first care models came out of the oven and we took them out to these clinical innovators, I held my breath, because it's agony to implement a new care model in a health system. Telling clinicians and people who are confident of how they do their work, we have a great idea as to how you can completely change your job, it tends not to go well. And so I just held my breath. But to the credit really of our fellows, of the first 4 care models that we designed, they now have we now have fish on the line in terms of health systems wanting to proceed with 19 different sites for the different care models all over the country. And it's turning into what I was hoping we'd at least get one time at bat for each care model, but it looks like for many of these it'll be a multi-site trial and informal trial, and so it's so far so good. Later, I think as we acquire more faculty, we'll move on to other phases where we move from the what to the how, and then from the how to one major component of the how, where I really resonated with what Jan and Molly said, is how do we begin to IT enable some of these care models? Because for example, in the world of ICU care that Molly talked about, the last time anybody measured it, to get care right for each patient per day took 175 different tasks. And that's for patients whose care is on a stable platform, where things don't happen, where you have to change them. You can quickly see that the ballet of perfect care is well beyond the cognitive processing capability of humans. And so I view the third phase of CIRC is the electronically enabled version of these, I'll call them clinical ballets, which is in essence what care over time, whether you're in an inpatient unit or whether you're living at home, is really all about.
Great. So we would like to open it up for questions from the audience. We have 10 minutes, so if you have any questions, please come forward.
Seems to me like some of the problems of implementing these better models is impeded by the training of doctors. They work individually. We don't train them to be managers. They're part of a work group, but not part of a team. And they're reluctant to give up their independence. Have you all had much experience with that? And do you see much opportunity to deal with providing services in a more efficient way in rural areas?
I think that speaks to the traditional model of medical care, which is, as Clay Christensen wrote about, physician on top as a wizard and the pyramid below. And that model is not sustainable because we don't have enough physicians, and it's also not a very effective model. So the model for the future has to be some kind of a team model where people share information and people have very different kinds of roles. As I mentioned, physicians will probably change their roles in large systems where they can be used most efficiently. But the training part is really interesting because my personal impression is that the new residents coming out are much more team-oriented and able to coordinate and work with other people than people who graduated in my day. And you can understand that because when physicians graduated in the old days, you have all the accountability. You'd have to take charge. And on you falls all the responsibility. But in a team model, as long as you have a framework for accountability, it should work fine. And that's the way you extend care, through technology and stuff. You have to do that. So I think things are changing. But you're right, the medical schools, I don't know. I can't speak for medical schools. I don't know what they're doing these days. But yeah.
Well, I think medical schools are doing a tremendous amount to both select students with a different personality mix and also to train them for teamwork. So that is helpful, and young physicians now in the first decade or two of their practice are much more likely today to be interested in those kinds of practice models. But also, you saw the information that Mark Bertolini presented. Well over half, close to 70% of all physicians are now employed by organized corporate systems, whether they're hospitals or KP or something different. So the residual number of physicians practicing in that old model is declining. And even there, even in the fee-for-service cottage industry, when you provide new incentives, it's amazing to see the crystallization of the liquid. I mean, I don't think anyone mentioned it, I'm also on the Aetna board. And one of the things that we've introduced is a strategy where we come in and partner with hospital systems and offer the information, the technology backbone to support physicians in doing Medicare Advantage and employee self-funded insurance plans, and then offering a health plan on the local market. It's been wildly successful, and we're getting 20-30% decreases in trend because the physicians, when they're given the right information at the point of care and the right incentive, change within 12 months. So, I mean, there's a secret of sort of combination here of the temporal trends in the general environment and then the specific opportunities you put in front of the physicians that I think is pretty exciting.
Thank you. This may be a softball for KP and a curveball for Molly. And Arnie, I think you had referred to this before, but for any given technology, let's just say the electronic medical record, will the business model and the alignment that an integrated system like KP has always trump the technology? In other words, a lot of technology innovations I believe, are trying to get over the inherent conflicts of interest between a payer and provider and make things different. Is it, for any given technology, will it always be better for an aligned system, an integrated system, and how can we think about that?
I think that's a really interesting question. I've never thought of it that way, but I think that at KP, the core motivation is to support the care model with technology. Now, up against that is the fact that these are fixed products. And vendors come out with products they designed 30 years ago. They're maybe not quite the way we would want them, but there's no choice. There's nothing else in the market. So in a way, it's like a dance, like a ballet. The technology is trying to keep up with healthcare needs, and the care models are changing. We've always had, we've had a four-point compass for our mission, which is quality of care, affordability, service, and professional satisfaction. And those have been core forever. So those will always be there. But how do you define that? And what does technology make possible in terms of new care models? That remains to be seen. Care models that can be vetted and proven and are effective. So, yeah.
What you say sounds like it should be right, but it's not my experience. So the tele-ICU is very good for the payers, and it also would be very good for us as a system, and it would be good for patients. The e-consult system that I was talking about would be very good for the patients, would be very good for us, and would be excellent for the payers. So we're actually into a new world where there are some pretty big things that can be done where the drag is the execution things that Arnie was saying about, can you actually get it off the ground and do it, and the sort of psychosocial retrograde tendencies of physicians that the previous speaker referred to, and administrators, to be fair also, more than the alignment.
So we have time for one more question. I know you're all waiting. Sorry, you can ask your question.
Sure. Dr. Chow, you mentioned Google Glass. How do you think that technology platform fits into your strategy? And how do you assess the various glass startups that are popping up?
I think we actually also applied to get a Google Glass, and the first thing we do is hack it. But I think that's I think the potential is huge. I mean, I was only half joking when I said it could be the next mobile device, because when a senior citizen can look at a pill bottle, see the barcode, and it can tell you when you should have taken the medicine, that's huge. when you get information linked into your medical record at the time you need it, that's huge. So I think the potential is huge, but again, as long as it stays clear of clinical care and it stays in sort of the consumer hybrid world, it'll be safe.
Great. Thank you. So please join me
Okay.
in thanking our speakers.
Okay.